Welcome back to the deep dive. Today we are tackling what is, well, arguably the most complex and sensitive situation a doctor can ever face.
It really is. We're talking about responding when a patient asks for assistance in dying.
And for those of you preparing for high-stakes exams like the MSRA, this isn't just a difficult topic, it's incredibly high yield. It tests everything.
It does. Our mission today is to, cut through all the emotional weight and just give you a clear, functional, and legally safe framework.
So we've distilled the official GMC guidance on this.
That's right. Specifically for the situational judgment test, where one small misstep in your response can, it can really change your score.
Okay, let's just get right into it then. Let's start with that moment of truth.
Okay, so imagine this. You're a foundation year doctor, you're on the ward, and you have a patient with a progressive, life-limiting illness.
You know them, you've been caring for them.
Exactly. And they pull you aside, they look you in the eye and say, "Doctor, I've had enough. I need you to tell me how I can end my own life." The tension in that room is just. It's immense.
Yeah.
What is your immediate professional action?
That one moment tests everything, doesn't it? Your empathy, your knowledge of the law, your duty of care.
All of it. And the core truth, the one thing you must hold on to for the SJT is this.
Okay.
While you are absolutely obligated to listen and to be compassionate, your professional advice must be strictly, and I mean strictly, confined to lawful clinical options.
Because encouraging or assisting suicide in the UK is a criminal offense.
It's a clear red line.
So here's the thing that gets really interesting for me. Examiners know this is tough. Why do they love testing this specific gray area so much?
Because it's high-stakes testing, plain and simple. It lets them test two massive things at the same time.
Okay, what are they?
First, your commitment to core GMC duties. Respecting human life, sticking rigidly to the law.
Yeah.
That's all in paragraph 2 of the guidance.
And the second thing?
This is the subtle one. It tests whether you can spot the difference between genuine compassionate listening and accidentally crossing the line into providing information that constitutes illegal encouragement.
So the trap isn't always obvious. It could be disguised as, just trying to be helpful.
Exactly. The emotional pull to help can push doctors, especially junior ones, right over that legal boundary. The GMC is so explicit about this.
What do they say?
They say respect for patient autonomy cannot, under any circumstances, justify an illegal action. The best candidates understand that here, legality is professionalism.
So if the law is that hard limit, what does the GMC absolutely require from us in terms of actual care? What's the minimum expectation?
Well, the GMC expects you to make the care of the patient your absolute first concern. And that means providing truly excellent clinical care.
Which includes what, specifically?
It means robust treatment for pain, for all distressing symptoms. That's a core duty. But, and this is crucial, the guidance also says you must respect a competent patient's decision to refuse life-prolonging treatment.
Okay, let's just pause on that for a second, because that specific point is where so many people get tripped up.
It is.
Refusing treatment that might lead to death is not the same as suicide. Can you just clarify that distinction?
Yes. It's a vital legal and clinical difference. The guidance is crystal clear. Respecting a competent patient's refusal of treatment, even if it results in their death, is a lawful clinical decision.
Whereas suicide is an active step.
Exactly, an active step to end life. Refusing treatment is about autonomy over your own body. The safest doctor has to know that distinction inside out. Respecting that refusal is professional. Assisting suicide is criminal.
So the safest doctor, then, is balancing this strict adherence to the law with really active, intentional listening.
Yes.
So what should a doctor actually do in those first few minutes after the patient makes that request?
They should listen, really listen, to the reasons for the request. This isn't just about emotional support, it's diagnostic.
What's the root cause?
Is it uncontrolled pain? Is it psychological distress, fear of dependency, spiritual angst? But at the same time, they must limit their advice only to lawful clinical options like advanced symptom management, specialist palliative care, that sort of thing.
That makes so much sense. That approach actually improves patient care on the spot, doesn't it? It forces you to assess what's really going on.
Absolutely. By focusing the conversation back onto what you can do, you ensure that all those unmet needs, physical, psychological, social, spiritual, they get assessed and addressed immediately.
That's how compassion and the law work together.
That is the sweet spot.
Okay, so for the SJT, you need a clear sequence. Give us the framework, the highest scoring stepwise approach the examiners are looking for.
Right. It's a clear 4-step framework.
Yeah.
And it's all about assessment and legal safety.
Step 1.
First, listen and explore. You have to listen with compassion, explore their understanding of their condition, the real reasons behind the request. Don't interrupt, don't dismiss.
Okay, step 2.
Second, state the legal limit. You must explain immediately, but also objectively and kindly, that it's a criminal offense for anyone, including you, to encourage or assist suicide. It sets the professional boundary right away.
Sets the frame for the rest of the conversation.
Precisely. Third, assess unmet needs. Proactively start assessing and addressing all their palliative care needs. Pain, psychological support, everything. This is your immediate clinical duty.
And the final step?
Fourth, offer lawful options. Provide objective advice only about what is legally and clinically possible. Focus on robust symptom management and comprehensive palliative care.
We need a way to make that sequence stick when you're under pressure in an exam. A mnemonic.
Of course. Let's use the mnemonic LAWS to govern your immediate reaction. It covers those 4 steps.
It's all AWS. I like it.
So L is for listen and learn the root cause. A is for acknowledge the legal assistance boundary.
Got it.
W is for work on unmet needs, pain, distress, symptom control. And S is for support lawfully through palliative care and sedation options.
That's very cool.
And for a visual cue if you need one, when a patient asks this, just picture a really comfortable, well-resourced palliative care bed. That is the lawful professional space you must operate within.
Anything outside that space is a risk.
A huge professional and legal risk.
Okay, let's talk about the common traps the MSRA uses. They're clever. They set up these scenarios around the little nuances of the law.
They do. So the first pattern we've already touched on, a patient refusing life-prolonging treatment.
Right.
What's really being tested is your ability to tell the difference. Refusing treatment is not suicide. The best action is to respect the competent patient's refusal and document it fully.
Makes sense. The second trap, I imagine, involves being asked for information.
Yes. The patient asks you to do some research for them or find contacts for specific methods. The temptation to seem helpful is massive.
But it's a trap.
It's a huge trap. What's being tested is your absolute adherence to that legal boundary. Any information that encourages or assists, even just passively looking it up for them, is prohibited.
So the best action is to gently redirect.
Redirect back to lawful palliative options and state the legal constraint again, very calmly.
Okay, here's a tricky one. A patient demanding specific, maybe excessive amounts of medication, hinting at stockpiling.
Yes. What's being tested here is the conflict between your duty to treat their symptoms and your duty to prevent an illegal act.
So what do you do?
You must provide appropriate symptom control. But you absolutely cannot provide medicines in a way that facilitates their stated illegal intent. You have to maintain professional vigilance over your prescribing.
Okay, and one final pattern. What if you're just uncertain? You don't know the exact law in some niche situation.
This tests your professionalism and when to escalate. Guessing is dangerous. The best action is always to stop and seek up-to-date legal advice.
From who?
From your defense organization, a professional association, or your employer's legal department. You aren't expected to be a lawyer, but you are expected to know when to ask for one.
That's a great breakdown of the patterns. Now let's talk about the specific trap answers, the ones that sound compassionate but score really poorly.
Right. Avoid these. First, referring everything immediately to the patient's GP or psychiatrist.
Why is that a bad option? It sounds sensible.
It scores poorly because it's a delay. A delay in immediate clinical care. You have a duty in that moment to listen and assess their current palliative needs yourself. You can't just pass the buck.
Okay. What's the next trap?
Debating the ethics or quoting case law. This scores poorly because your job is to provide compassionate clinical care, not to get into a philosophical debate with a vulnerable patient.
That makes sense. Keep it clinical.
Always. Third, and this is a big one, agreeing to discreetly look up information for them. It scores terribly because it directly breaches the legal boundary. There is no discreet way to break the law professionally.
Number 4.
Arguing with the patient about their choice. Trying to guilt them into changing their mind. This just lacks compassion and disrespects their dignity. Your approach has to be respectful even while you maintain those professional limits.
Invaluable clarity. Okay, let's do a quick fire round just to cement the right response.
Let's do it. Quickfire SJT calibration. If a patient expresses overwhelming concerns about their pain getting worse.
You do assess and propose advanced symptom management immediately.
Perfect. If the patient asks for your personal opinion on the ethics of assisted dying.
You do not offer a personal opinion. Stick strictly to lawful clinical facts and GMC guidelines.
Yes. And if a patient who is fully competent refuses a treatment that is keeping them alive.
You do respect their decision. This is explicitly not considered suicide.
Exactly right.
That brings so much clarity to what is an incredibly difficult area.
Yeah.
So for the junior doctors revising right now, what are the 3 non-negotiable takeaways?
Okay, 3 things. 1, assisting or encouraging suicide is a criminal offense. Your advice must always stay within those legal limits.
Bingo.
2, you have an absolute immediate duty to provide comprehensive, compassionate palliative care. That means proactively addressing all their needs, physical, psychological, and spiritual.
And the 3rd key point.
3, respecting a competent patient's refusal of life-prolonging treatment is a lawful clinical decision. It is not considered suicide.
This guidance is tough, but knowing these boundaries is what ensures compassionate care and protects your career.
Absolutely. Apply that LAWS framework consistently.
Study smart and score well.
And for more high-yield revision content that's specifically tailored for the MSRA SJT, you can find a load of great resources at passthemsra.com.
Before we close out this really vital deep dive, let's leave you with one final thought to mull over. The laws and the professional guidelines we've been talking about today, they're the product of decades of debate. In a time before the internet changed everything.
That's a good point.
So considering the rise of easily accessible cross-border digital information, how might a doctor in 5 years' time have to address this same request, especially when things like legal jurisdiction and what counts as digital encouragement become even more complex? It's just something to think about as you step into your future roles.